Welcome to Essential Neuroanatomy Review, Lesion Localization in Neurology, Spinal Cord, Peripheral Nervous System, and Select Symptoms. This is David Lee Gordon, Professor of Neurology. For Essential Neuroanatomy Review, the learning objective is to localize a lesion in the nervous system based on clinical presentation, that is to say, the history and examination. Let's first review spinal cord anatomy. And this is an axial cross-section of the spinal cord. You can see that posteriorly, the dorsal ganglion receives sensory nerve roots from the limbs and body. Both the large fiber neurons that carry proprioception and vibration, that's represented in green, and the small fiber nerves carrying pain and temperature, represented by the yellow nerves. The large fiber proprioception and vibration nerves enter into the ipsilateral posterior columns. And the joint position sense or proprioception and vibration tracts are then sent upwards rostrally to the thalami, to the ipsilateral thalamus. On the other hand, the yellow pain and temperature fibers cross. They go across the front of the spinal cord there in the anterior white commissure. Commissure means a crossing, so anterior white commissure, and go to the opposite anterior spinal cord or ventral spinal cord and go then upward in the spinothalamic tract, carrying pain and temperature sensory tracts up to the thalamus, now contralateral to the body, although ipsilateral to the tract. The cortical-spinal tracts, or lateral columns, carry the upper motor neuron fibers down from the frontal lobes. They then synapse on the lower motor neurons in the anterior horn cells, and then the anterior horn cells are the nuclei for the lower motor neurons, and the lower motor neurons exit the spinal cord via the ventral roots. We use the term myelopathy for spinal cord diseases or spinal cord dysfunction. Myelo refers to spinal cord, and diseases is represented by pathies or dysfunction pathies, myelopathy. The 5 key clinical findings of a myelopathy occur because once the spinal cord is injured, everything below it is not connected to the brain. So there is dysfunction below the level of a spinal cord injury. And those 5 key clinical findings are weakness in the limbs, bilateral weakness usually. And this bilateral weakness can be either a quadriparesis if the myelopathy is high enough up and to involve arms and legs, such as in the cervical region, or a paraparesis, especially if it's below the arm involvement, so in the thoracic region, for example. The sensory loss occurs below the spinal cord lesion, and if this occurs over the thorax, we call this a sensory level. A bit more into that. There is then dysfunction of the autonomic nervous system as well. 3 components of the autonomic nervous system, 3 functions of the autonomic nervous system do not work. There's urinary incontinence, and specifically an upper motor neuron bladder, which we've discussed previously as small spastic bladder with frequency, hesitancy, urgency, and small volumes. Constipation, when the parasympathetics are specifically not working in the spinal cord, it results in constipation. And then there's sexual dysfunction, and for men that is usually erectile dysfunction, and for women that's usually anorgasmia. Radiculopathy is the term we use for dysfunction of a nerve root. A radicule refers to nerve root. And radiculopathies usually have sensory loss in a dermatomal pattern. A dermatome is a sensory distribution of an individual nerve root, and that dermatomal pattern is a strip of skin, is the best way to describe that for your patients, a strip of skin correlating to a specific nerve root distribution. folks with radiculopathies tend to have radiating pain and sensory loss in a dermatomal pattern. And it's key on history to determine where the pain ends. When someone says, I have pain that shoots down my arm, that is not sufficient. One must say, well, does it go to the thumb rather, to the middle finger, to the little finger? That tells you if it's C6, C7, or C8, for example. Or does it go into the big toe, L5, or the little toe, S1, for example, if it's down the leg? And the sensory loss would be in the same exact region as where the pain ends. Strange enough, they have pain in an area that has decreased sensation. That's typical. And the only sensory modality to test is pinprick. Don't worry about vibration and even light touch. You want to really go for pinprick in the middle of the dermatome where they have the problem. So if they say, I've got pain radiating to my thumb, you want to take a pin and test C6 on one thumb versus C6 on the other thumb. Weakness in radiculopathy may occur if you involve the motor nerves in a lower motor neuron pattern. That is to say, there'll be atrophy and fasciculations if it's there long enough in the select muscles innervated by the nerve roots. And typically the reflexes are decreased. It's a peripheral nerve problem, lower motor neuron, so the reflex will be decreased or absent in reflexes innervated by the affected nerve roots. By far, the most common radiculopathies are cervical and lumbosacral. Why? Because those are the areas where we bend. We bend the spine at the neck, and we bend the spine at the waist. So bending frequently can lead to either osteoarthritis, an osteophyte, or herniated disc, either of which can compress a nerve root. Peripheral neuropathy is a very specific term that is also called polyneuropathy. It does not refer to any peripheral nerve problem. It refers to a specific syndrome in which there is diffuse distal symmetric nerve dysfunction. It can be either motor alone or sensory alone or both. And it is due to various systemic conditions. The four main categories are metabolic, toxic, autoimmune, and genetic. The most common of the metabolic disorders that cause a peripheral neuropathy or polyneuropathy are diabetes mellitus and B12 deficiency. The most common of the toxic would be alcohol, chronic alcoholism, or chemotherapy. But there are also medications can do it, for example. Autoimmune disease and genetic are other two categories. Now, these peripheral neuropathies can be primarily axon involving or myelin involving on their pathology. And in general, they'll have decreased reflexes, hypo or areflexia, and they'll have distal sensory loss. Now, these distal sensory loss can involve either the large nerve fibers, vibration and proprioception, or the small nerve fibers, pain and temperature, either one or both. For example, in general, B12 deficiency tends to cause a large fiber neuropathy with only vibration and proprioception problems, whereas diabetes does both, large and small. And in general, chemotherapy involves small nerve fibers. So knowing the actual modality that's affected can help you figure out the etiology, actually. This peripheral neuropathy involves the longest nerves first, and that's the feet. So by far, the most common presentation of a polyneuropathy is a stocking distribution alone. Now, the other texts love to talk about stocking glove, and that can happen. It is not as common as pure stocking. It's much later in the involvement that the hands also get involved. It's usually just the feet, stocking distribution. Second most common, stocking glove. A third and least common involvement is a stocking glove and shield, because the thoracic nerve roots coming out of the spine in the back, the distal parts of those nerves are actually over the chest. The reason why this can be important is because sometimes it can fool you and you think someone has a myelopathy because they have sensory loss on the chest, but unless you also check the back, if the back is normal and the chest is abnormal, it's not a spinal cord problem. It's one of those unusual stocking glove shield distribution peripheral neuropathies. What's interesting about peripheral neuropathies is, like the radiculopathy, there is sensory loss, but also pain in the same distribution, neuropathic pain, and a phenomenon called allodynia, where things that normally don't cause, stimuli that normally don't cause pain, such as touch or sheets even, light touch, can cause pain. That's neuropathic pain. The term myasthenia specifically means disease of the neuromuscular junction. And the key findings are proximal symmetric weakness that we sometimes summarize as hair, chair, and stair weakness, meaning they have difficulty raising their arms to groom their hair, difficulty rising from a chair, and difficulty going upstairs. These patients will have normal sensation and reflexes. And the key to knowing it's myasthenia specifically is not just the proximal symmetric weakness, but the fact that the weakness is fatigable. It's worse with exertion, such as worse when they're tired or end of the day. Maybe they go on a hike and they're normal, but towards the end of the hiking, they can't lift their legs up over rocks or logs, etc. Ocular weakness is common in myasthenia. So patients can get double vision and ptosis, especially when they're tired or at the end of the day. And they can have oral and facial, known as bulbar weakness, with a nasal speech. It affects the muscles in the sinuses there, and language is affected. They have nasal speech. They can have slurred speech, dysarthria from motor weakness, trouble swallowing, dysphagia, chewing problems, eye closure, and facial weakness. And again, fatigable. So maybe they can eat breakfast normally, but when they eat dinner, it's more difficult. Or maybe they don't like to eat, things that are hard to chew, because when they chew too much, like pureed foods, for example, is better, because if they chew too much, it starts causing weakness and trouble swallowing. The most common cause to think about is myasthenia gravis. Myasthenia gravis is a postsynaptic muscle, in other words, acetylcholine receptor antibodies due to autoimmune disease. There's also the phenomenon called Lambert-Eaton myasthenic syndrome, which is a presynaptic antibody, and it's due to a paraneoplastic syndrome most of the time. And there are other potential causes of myasthenia as well. We use the term myopathy to refer to disease of the muscle. And like myasthenia, these patients present with proximal symmetric weakness, the hair, chair, and stair weakness. And like myasthenia, they have normal sensation and reflexes, although there's one type of myopathy called hypokalemic periodic paralysis that can lead to decreased reflexes. Unlike myasthenia, people with myopathy have no fatigability. The weakness is constant throughout the day. There's no change with exertion. They don't always, but they may, depending on the type of myopathy, have myalgias, which are muscle aches and pains. And there are many different causes of myopathy, including polymyositis, dermatomyositis, muscular dystrophies, hypo or hyperthyroidism, drug-induced myopathy, especially steroids, and hypokalemic periodic paralysis. Previously, we looked at homonymous visual deficits. Now let's look at heteronymous visual deficits, in which the visual field loss is different in each eye. And there are two kinds of this. There's monocular visual loss, in which the lesion is anterior to the chiasm. And there's bitemporal hemianopsia, in which the lesion is at the chiasm. So let's look again at the visual pathways, this view from the top of the head, axial view. And you see that the optic nerve, N, labeled with N, comes from one eye. So if one has an optic nerve problem, the patient will have monocular visual loss. And it will be heteronymous, different in both eyes. The left eye is normal in this case. The right eye is not normal. You can't see. A lesion at the chiasm involves only those fibers that see the temporal fields, the nasal fibers that see the temporal fields. And so they'll get bilateral temporal field abnormalities, but they can see inner vision. The nasal fields are intact. It's called a bitemporal hemianopsia. The most common cause of a chiasm lesion, it'd be things like a pituitary adenoma or craniopharyngioma. I would like to point out here, while we have the moment, to notice that when you are depicting visual fields on a paper, ophthalmologists have gotten into the habit of keeping right on the right, left on the left, as if a patient is staring into the page. So unlike a lot of other fields in which, for example, radiology always has left on the right, right on the left, but in ophthalmology, the right eye is depicted on the right and the left eye on the left. One cause of monocular visual loss is retinal artery occlusion or infarctions. And the central retinal artery takes off directly from the ophthalmic artery at a minimal angle and thus is very susceptible to emboli, coming, for example, from the internal carotid artery bifurcation or the bulb, or potentially even from the heart, cardioembolism, or maybe even from hypercoagulable states. The retinal artery within the eye, within the retina, divides into the superior and inferior branches in the optic cup. And that's an important thing to remember as we talk about pathology. Retinal artery occlusions are manifested by sudden, painless, monocular visual loss. Those are the big three: sudden, painless, monocular. And again, the emboli from the heart, artery, or blood, as we just described, are the causes almost always. And the two main subtypes are central retinal artery occlusion and branch retinal artery occlusion, CRAO and BRAO. The central retinal artery occlusion is manifested by complete monocular visual loss on most occasions. The branch retinal artery occlusion, however, would be an altitudinal or wedge-shaped deficit. If it involves the entire branch, then the patient cannot see entirely upper vision or lower vision in one eye. If someone has that symptom, I cannot see above the meridian or I cannot see below the meridian, it has to be this syndrome because of the unique anatomy in the eye where the branches of the retinal artery are superior and inferior. Sometimes it's a branch of the branch and you get this wedge-shaped deficit in their vision. Another potential cause of monocular visual loss is dysfunction of the optic nerve, cranial nerve 2. Now, optic nerve 2 is actually an extension of the retinal ganglion cells and part of the CNS. We call it a nerve, but it's actually part of the central nervous system. It is the afferent limb of the pupil light reflex. Remember that cranial nerve 3 is the efferent limb, specifically the Edinger-Westphal component of parasympathetics. Disease of the optic nerve is called optic neuropathy, and there are four main types of optic neuropathy based on the anatomy. So first of all, the optic nerve is supplied by the posterior ciliary artery, and it is especially prone to being involved with giant cell arteritis, a condition that affects only older patients, people over 60 typically, and you can get ischemia to the anterior part of the optic nerve. We call that the anterior ischemic optic neuropathy, or AION. There's another form of AION that is non-arteritic that is due to hypotension. What you'll find is the disc will look swollen because the anterior optic nerve is infarcted and the patient has decreased visual acuity. The optic nerve is also myelinated, so demyelinating diseases such as multiple sclerosis or neuromyelitis optica or myelin oligodendrocyte glycoprotein antibody associated disease, better known as MOGAD, and there are other conditions too, many other ones, that can cause problems with myelin in the optic nerve and cause vision loss. These folks typically have more loss of color. They often have color desaturation. They will have potentially, they don't have to because it depends on where, so the swollen disc presence depends on where the demyelination is. If it's at the bulb, at where you see it, you'll have a swollen disc. If it's retrobulbar, behind the bulb, you will not see the actual swollen disc. But they will have poor visual acuity, and they often have pain and eye movements. That's the most common thing with these optic neuritis. The optic nerve is surrounded by the meninges, so increased intracranial pressure can also cause problems with the optic nerve. And when you see a swollen disc with normal visual acuity, that is usually papilledema. The term papilledema does not mean swollen disc. It specifically means swollen disc when it is due to increased intracranial pressure. And so true papilledema, a swollen disc, is going to have normal visual acuity. You don't affect visual acuity when the disc is swollen. However, long-term papilledema can end up compressing that optic nerve so long that it makes it have poor visual acuity, but at that point it won't be swollen looking anymore, it'll be pale. So a pale disc with poor visual acuity is a sequela of long-term increased intracranial pressure. The optic nerve also obviously emanates from the globe, and if you have increased IOP, I apologize, IOP, intraocular pressure, that's glaucoma, then you will start compressing the optic nerve head, and you get, on exam, the ophthalmologist will see what's called optic cupping, and the patient can in fact become blind and have poor visual acuity long term if the glaucoma is not treated. Lesion localization for a headache is nearly always the meninges, no matter what the cause of the headache. Meninges are a 3-layered sac surrounding the brain, brainstem, and spinal cord. Pain nerves line the meninges in the trigeminal nerve in the face, the cervical nerve roots in the back of the head and neck, the thoracic nerve roots in the chest, and the lumbosacral nerve roots in the groin and legs. Pain nerves in the meninges are turned on when the meninges are stretched, irritated, ischemic, or sensitized. So the meninges are lined with pain nerves, and there are pain receptors throughout the meninges. Meningeal nociceptor pain receptor stimulation occurs when the meninges are stretched, and the two main ways to stretch the meninges are to increase intracranial pressure or to decrease intracranial pressure. The meninges are also turned on, the pain receptors are turned on when the meninges are irritated. And the two main things that irritate meninges are white blood cells in meningitis, and remember there are both bacterial and aseptic versions of meningitis, and RBCs, red blood cells, and we mean by that subarachnoid hemorrhage. The other way to turn on the pain receptors in the meninges is to make the meninges ischemic, and this only occurs in the condition called giant cell arteritis, sometimes known as temporal arteritis, but it doesn't only involve the temporal artery, so it's, I think, better to call it giant cell arteritis. It only occurs in older folks over 60 who get ischemia in the middle meningeal artery from that condition. And then you can turn on the meningeal nociceptors through sensitization. That means specifically nociceptor agonist stimulation, usually by the chemical called calcitonin gene-related peptide, or CGRP. And this is how you get headache in primary headache disorders, the most common being migraine, other examples, cluster, etc. And how you get constant headache in the condition medication overuse syndrome or medication overuse headache. There are other versions of head pain that we don't usually call headache, but a patient may. They can be caused by carotid dissection, vertebral dissection, or trigeminal neuralgia. Dizziness is a term that is unfortunately commonly used not only by lay folks, but also by many doctors. It is extremely nonspecific and non-localizable. It doesn't mean anything to a neurologist. You must confirm what do you mean by dizziness. And there are 4 main types of dizziness: lightheadedness, vertigo, motor ataxia, and sensory ataxia. And they all mean very different things in terms of localization and etiology. Lightheadedness is the sense you're about to faint, and it is always due to hypoperfusion of the brain. Another term for this is near syncope or pre-syncope. The causes include hypovolemia, left ventricular outflow obstruction, cardiac arrhythmia, excessive blood pressure medication, neurogenic syncope, which itself has many causes. There's vasovagal, there's dysautonomia, and dysautonomia can be caused by neurodegenerative diseases, by neuropathies, or migraine. Just so you understand, I'm not saying the term POTS here, because I think POTS, postural orthostatic tachycardia syndrome, is actually a migraine variant, and that can be explained some other time. Vertigo does not mean spinning. Vertigo means hallucination of movement, and while spinning may be the ultimate form of that, it can also be a side-to-side movement, a back and forth movement, rocking. Any hallucination of movement is vertigo. Vertigo is always neurologic, always. And it can be due to vestibular dysfunction, okay? But that is not only in the ear. It can be due to cranial nerve 8 or brainstem. It can be cerebellum, it can be temporal lobe, it can be the insula, it can be a lot of other places. There's a peripheral version in which the ear rocks, otoliths, are misplaced in the ear. This kind resolves when you're stationary. If you do not have vertigo that goes away completely when you're still, it's not due to the ear rocks. It's not due to benign positional vertigo. Motor ataxia or cerebellar ataxia is a coordination problem. Sometimes patients say I'm dizzy when they mean they have imbalance. That's what we mean by this. Gait imbalance without vertigo. And the motor ataxia is not affected by vision. What I mean by that is looking doesn't help. Looking doesn't help. Even when they're looking where they're going, they have imbalance. The most common location for a cerebellar lesion is in the cerebellar hemisphere. So a cerebellar hemisphere lesion will cause you to fall to the side of the lesion. So if they veer and fall specifically to one side, it's more consistent with a cerebellar hemispheric lesion. It can also involve the cerebellar tracts and peduncle as well as the cerebellum itself. Sensory ataxia is actually a proprioception problem, but the chief concern is going to be usually imbalance, again, without vertigo. But if you take a careful history, you'll find in these folks that this imbalance is better with either vision, so in other words, worse in the dark when they go to the bathroom at night, or worse in a movie theater, better in the daytime, or better when they're looking, and better when they touch things with their hand, because their hand tells them where they are, right? So they have to touch the walls or use a cane, and that's better. For example, when they in the shower, when they close their eyes to wash their face or hair, if they put their hand on the wall, they don't fall, right? They have to do that every time they know. This is due to usually either a large fiber peripheral neuropathy, such as that can occur with diabetes or with B12 deficiency, or a posterior spinal cord lesion. Those are the two main localizations for a sensory ataxia. Thank you for viewing and listening to this presentation. This is a DLG Insight production, innovative neuroscience ideas and thoughts on education.